all the participants. And as I said yesterday, kindly keep your videos on and be interactive as possible. Thank you so much whoever have joined us on time. Today we'll be discussing about step 1 on the analgesic ladder and a little bit touching upon pain and moving on to these steps. We have Dr. Radha as our faculty. Dr. Radha, her background is she's an anesthetist. She's been working in the UK for many years, mostly in pain management and in ICUs. And she used to take time off to volunteer in volunteer in palliative care services in Chennai. And now for the last year, she's been associated with pallium training and education across the country in many places, not just virtual education. Thank you so much, ma'am, for today's session, and over to you.
Thank you very much. A big thank you to Pallium for giving me this opportunity. And nice to see all of you. The main vision of Pallium India is to take palliative care to the needy. That cannot be done with each one of us participating and actively working on it. So for Dr. Rajagopal's vision to come through and be effective, all of us have to do our best. So with that, we'll go on to our session. Basically, in your schedules, you will have few sessions on pain. Why so much for pain? Because when you take palliative care, nearly 60 to 80% of the symptom management, which all of you will have to do, will be pain and breathlessness. So pain forms a big part. So we need to know about it very well so that we can manage it well too. Okay. So some things like nearly 2-3 sessions you'll be having on pain. So already you've had a session where you've seen about the definition. But the definition is so important because initially one definition was done in the 80s. And then in July 2020, they have done a little tweaking of the definition, mainly to make sure that it is understood well and treated well. So next slide. So what you're seeing is the basic definition, which all of you will be aware. It's just not the physical symptom alone. It has also the emotional, sensory, all element to it. And in July 2020, they added on 6 more factors to it. Next slide. So what are the 6 factors is what is given here. We are just going to touch a little bit only on this so that when we go on to the next ones, so that we know what we are looking into. So what are the 6 factors added are, you have to give importance to the personal experience of the patient, and you have to understand what's the difference between pain and nociception, and also have in mind that life experiences do have a role in the way the pain presents, and you have to give due respect to what the patient says. Expression of pain needs to be respected. And generally, pain is taken as a sign or adaptive thing. But the same thing, if it continues for long, it becomes a nuisance or a disease. And last but not the least, verbal expression is not the only way to express pain. There are many other ways also. For example, patients in intensive care, do they speak? They have a tube in all ends. But still you can assess their pain by seeing the vital signs, by seeing sometimes they may have tears in their eyes. So there are very many ways of finding out pain, not only with the verbal expression. Next slide. And we'll go to the next one. So this one is a schematic representation of the pain pathway. I think you've all had some information on this yesterday. Can someone tell me, like, what are the important nociceptors that you could say? Is like, do we feel the pain only in the skin, or are there any other, where are the sites that you have or express your pain or feel your pain? Either you can type or unmute and speak or anything is fine. So what I'm trying to ask is, like, you have various places, like you have skin as one of the point, you have joints, you have organs. Is someone trying to say something? Nothing in the chat.
Somatosensory and visceral.
Somatosensory visceral, yes. Yes. So that's what. So we have various receptors in various places, stretch receptors, pain and pressure receptors, like that. You have various types of.
Dr. Krishna says somatic and visceral receptors, polymodal nociceptor.
Pain is transmitted to the nerves and is usually opioid sensitive. Okay, thank you. So you have various. So from the point, like from the skin, you have various receptors, and then you have the inflammatory mediators, and then the afferent, the central, you have the dorsal horn and the crossover. Everything is important. And then you have up to the brain, then you have the descending pathway. See why all this is important, because if you understand this, only your management you can do effectively. So you have the whole arc from the point of stimulus to the brain, and then the descending pathway back with the efferent to the site. Okay. This you have. It's better that if all of you have this in mind, because you will have to connect everything to this to understand it. Okay. Next slide. So the important thing to understand is what's the difference between nociception and what is pain. See, nociception, as is given here clearly, it is just the detection of the stimulus and followed by transduction, or as we saw in this pathway, to the central nervous system and then return from the brain to the periphery. So that is nociception. Whereas you see on the other side, what is pain? It refers to the product of higher centers processing it, and that is what adds on to the unpleasant emotional element, what is generated in the nervous system. Next slide. Why is this so important that we need to understand? Or that simply you can say this whole pathway is not a hardwired system. So there's no only one way or one method only it should respond. It can respond in various ways. That is why we have a big array of different types of symptoms, what the patient presents to us. That's what is mentioned here. The mechanism by which the damaging stimulus in the body is perceived as a painful one is a complex one. The complexity of the process results why? Because it's not a hardwired system, but exhibits plasticity. That any plasticity is the word to be understood here. What it does, it enables to modify its function. So that's why it's not hardwired. It's not only one way. So it can present in different ways. Okay. And generally, pain serves the purpose to prevent tissue damage. Like, for example, appendicitis pain. So you know that pain is the cause for something. But always it may not be so. Under certain conditions, it can become maladaptive and become chronic pain. Okay, when it becomes chronic pain, it becomes a disease by itself. That is what is important. So the protective function is lost and it becomes a pathological. Next slide. So what is neuroplasticity? It is the capacity of the neurons, as I said, to change. They may form new networks, and they can have or create new connections. For example, it could have just been a sensory stimulus, but the surrounding sympathetic can get activated also because from that original stimulus. And there can be extra behavioral changes which can happen. And that in turn results in damage or dysfunction. Next slide. And generally, there are a lot of modulations which can happen. It could be a peripheral sensitization or a central sensitization. Okay. Peripherally is what happens at the point, what we saw from the stimulus, more mediators, that mediators quantity can increase. Ectopic firing, what will not fire, can reduce the threshold. So all these type of, that is what is said as not hardwired. So why to understand all this is important, because all these are how a patient presents in different forms of pain. It is not simple one type of nociceptive pain alone. Okay, that is the important thing to understand from this. So in the modulations, you have peripheral modulations and central modulations. To make things simple, peripheral modulation or peripheral sensitization is what is expressed by the chemical mediators. Whereas the central sensitization is something which can be explained in a simple way. The normal book term, what you will see is wind up and central sensitization. For that, can someone tell me what is amplification? Simple word meaning for amplification. Or what does an amplifier do?
There is decreased pain threshold.
Yes, one that is right. One of the mechanism is that.
And some sleepy neurons becomes active.
Yes, thank you. Another one.
And those who are firing becomes more active compared to previous time.
See, for example, you can tell it in other words, like small stimulus, more response.
More allodynia.
See,
Allodynia and hypertension.
no, basically, what does an amplifier do? It enlarges or makes it more. So exactly that is what is done. Basically, wind up and central sensitization are amplification. So for that, as Dr. Manoj Sharma, as Dr. Manoj Sharma mentioned, it could threshold variation. Threshold could be lowered, or small stimulus can make a large response. So these are the things why you need to be aware. And if it is wind up, it's a short lasting response. If it is central sensitization, it's a long lasting response. That's the main thing to be aware of that. Next two slides should be the same. That is what is explained. Go to the next one. And in neuropathic pain, see, in neuropathic pain, it could be either due to a direct injury or due to a potential injury, and due to various other causes, what I mentioned in this slide, like it could be due to ischemia, trauma, infection, tumor. All these can cause, especially malignancies, radiotherapy, chemotherapy, everything can cause neuropathic pain. Okay, so the etiology could be very, very varied as the cause for neuropathic pain. And the modulations, or what we have seen before, are the same for neuropathic pain also. I think the next slide will be that. So that's what, these are all what we have seen. The other thing is that there could be some altered gene expression also. And all the rest, what we have mentioned before, is what is mentioned in this slide. Next one. Next one. So central sensitization is what we saw. This wind up and central sensitization. Basically, wind up is short lasting. Central sensitization is a long lasting one, which can stay on for a long period. See, when you see about this, this is something, one bit of physiology or something which we need to be aware of. This is called as the gate control theory of pain, which was found in 1965 by Malzac. So basically, when a child falls down, what do? Child falls down and hits his knee or ankle or whatever it is. What would any one of you will do? All of you know the answer, but you only have to tell. I am not going to answer for this.
We will press there, ma'am, and we will
Huh?
Distraction.
distract.
No, not distraction. Anything else?
Rubbing of the
Very good. Thank you very much. Even you go hit your head somewhere, what do you do? Immediately you rub. That is exactly that mechanism. By when you rub, everyone feels. Do you feel some relief, or you still you rub without any reason?
we will get relief, ma'am, because A beta fibers will be stimulated.
Correct. So that is what was found out by this gate control theory. That's what is depicted in this figure. For example, normally pain is transmitted through the C fibers and A delta fibers. So whenever C fiber is stimulated, you see the picture on the left side. When the C fiber is stimulated, the A beta, that is a large fiber, and the inhibitory, again, we'll go back to that pathway that we saw, the descending inhibitory pathway is inhibited. So if you see in that first picture on the left, you see the pain is perceived. So similarly, in the second picture, the C fiber pain stimulation stimulus is there. But when you rub, the large fibers are stimulated. So the large fibers are the A beta fiber. When the A beta fiber is stimulated, that inhibitory pathway is stimulated. So you don't perceive the pain. So that's why if you see on the right side, the pain perception, you've got a red mark there. So this is the mechanism for rubbing. This is the mechanism how TENS works. So this is an important thing to understand. So based on this theory only, pain relief is obtained. So this is one of the important things. All TENS machines work on this principle only. So this is something to be understood and kept in mind. Okay, because we don't do that rubbing just without any reason. So as I said, no, whenever a child falls or hits, you just rub on this site of injury. Okay, so this is the mechanism by which it works. Next slide. See, the whole thing what we saw is given with the medications. We'll see the slide once again later. I think now you go leave it there or go back to the previous slide. So, like, you've all had this session yesterday and today. So, if someone could tell me the various types of pain, what you're aware of so far.
Pain is divided. Pain may be acute, subacute, or chronic, and pain may be nociceptive or neuropathic. And in nociceptive, it is somatic or visceral. Usually.
Thank you very much. What do you do, Dr. Manoj?
Yes, ma'am. Ma'am, I'm in pain management, ma'am. I'm doing fellowship in pain management.
Pardon me?
I'm doing fellowship in pain management, ma'am.
Okay. So anybody else wants to add on? Thank you for all that. There are some more which you can add on. Myocardial infarction, what are the types of pain that you know?
Myocardial infarction, visceral pain. It is referred pain, sorry, referred pain.
So, the rest also can participate and see, because all these are basic stuff. For example, next, when someone has a laparoscopic surgery, what do you advise? Post-operative advice, what would you give? Because nowadays, every surgery is laparoscopic, be it knee or hysterectomy. Is that right or not? So what is the advice? What type of pain there and what would you advise?
Shoulder tip pain.
Yes, very good, Shika Gupta. Why do you say that? Why do you pre-warn them about shoulder pain? What pain is that?
That is referred pain phrenic nerve stimulation from the diaphragm.
Exactly. Thank you. Very good. Because the inflated, how do laparoscopy happen and what is the cause for that referred pain?
Capnoperitoneum.
Pardon me?
Capnoperitoneum leads to
Yeah,
this.
exactly. So that's what. So they try to take out as much gas as possible before completion of the surgery. But still some amount of gas could be there. And that going under the diaphragm irritates, like stimulates the phrenic nerve, and you get pain in the shoulder. So the patient may get worried. "Oh, what is this? I had surgery for something and I'm having pain in my shoulder." So that is what you tell them so that they are not alarmed. And that is a type of referred pain. So pain as such, as we have seen, it can have all these types. So it's just not one simple thing. So acute and chronic difference is done by the duration of time. Okay, short term, long term. And then you have different types, as you said, visceral pain, somatic pain, all that is depending on, we will go to the next slide. In this, you have got, see, acute pain, chronic pain, somatic pain, visceral pain, basically what we have seen. Next slide. So in neuropathic pain itself, you have these four things, which everyone, maybe this allodynia and hyperalgesia are new terms which you will be coming to your when you're reading more about pain. That's what you would have been listening in the last couple of days. So these two are important because many times patients, without their knowledge, they will be telling this. It's our duty to pick up. Okay. For allodynia, commonly, can anyone tell how a patient will express?
Pain results from non-painful stimulus caused by if pain is caused by non-painful stimulus like some touching the surface or means when wearing clothes can cause pain.
Correct.
That is
That's what
allergen.
I was waiting for. Touching, that touch doesn't cause pain. Otherwise, we won't do handshakes, isn't
Yes.
it? Normally, touch doesn't cause pain. But when touch causes pain, or normally how patients come up to us telling us, my own clothes, when that cloth touches, my dress touches my knee, for example, if they're having pain in the knee, if my own dress touches my knee, I am in agony. So that is something very difficult, isn't it? So they will avoid people going near them. For example, because they're so scared if someone touches it without their knowledge, because generally there's no pain to touch. So everyone will not be aware of it. But someone accidentally goes past them or touches them without their knowledge, that causes so much pain. That is what is allodynia. Pain resulting from a harmless or a non-painful stimulus. And next is hyperalgesia. Something which should cause less pain causes more pain. So these are two things very significant or clinching the diagnosis type of symptoms for neuropathic pain, which as you all see patients, you will see them coming up with these symptoms. So that is something to be kept in mind. Maybe the next presentation, because that I've got. No, go back to the. See, this is something from pain point of view. We saw the definition. Okay. In the definition itself, you have seen what are all the components. So in this slide, it is given a little bit more in detail. Okay, what are the aspects you all have to think of? Because in the definition, it had sensory, social, psychological. So normally this is mentioned as total pain. So you have to have these in mind to see. So the eyes will not see what the mind does not know. Okay. So basically you have to be aware of things. So even this we were taught when we did as medical students. Our prof used to say the stat will not hear what the brain does not know. Okay, so these are all basic stuff. So our knowledge is base foundation. So for all of us to be aware, so salient points I would say physical pain, you know all the symptoms we have seen. Psychological pain. The pain is what causes all these anger, anxiety, depression, fear. Fear is the most important thing. Fear of unknown, fear of future, and that is what is causing a great amount of change in personality and everything. Okay, and social pain is something they're unable to do, dependency, helplessness, all those type of things. Social, financial, everything can come into that. And then you have, last but not the least, spiritual element also, which also plays an important. Next one. I think next we'll have. We have seen this. Go back to the previous one. Yes, please. See, next is assessment of pain. What are the ways at present, like other than Dr. Manoj Kumar, is anyone already working or deals with seeing patients with pain?
Acute pain, we all manage. Chronic, to some extent.
So acute pain in this, yes, generally, like you can I get more information that, like, do you say like as a family physician seeing patients, or
No,
is it?
as an anesthetist, ma'am, acute pain
Yes.
services we
Okay.
provide in the ward also.
Yeah, very good. That is what I just wanted to
And
give
chronic
that.
pain, we run a clinic, but all of us don't go and attend it. It's on a
Okay.
limited basis.
So maybe some specialists will be doing that. Is that right?
Yes, ma'am. Yes, ma'am. Yes.
Yes, yeah. See, very good. Thank you very much. That's all. See, because for everything, no, assessment has an important role. Now, I would like to answer, give me a couple of reasons why we need to assess.
To quantify the
Quantify.
pain.
Okay, one.
And to see also whether the management which we are giving is actually improving this.
Very good. First to
Improving the
quantify,
pain.
to know what to give, and next to see what I'm giving, is it working or not? Fine.
Is it working?
Anything more to that? Other
Ma'am?
than these two, is there any?
Please
Go
go ahead, Ruchi. Ma'am, we can also use these pain scores, pain scales to know the type of pain, whether it is neuropathic pain or non-neuropathic pain also
Correct.
can be delineated by using these various scales.
Very good. So that's all. So thank you. That's all. So it is just not only for assessment, then finding out outcomes or whether our treatment is being effective. And above all, see, all these data, what you collect will be useful not only for us and the current population. All these data can be used for data analysis in so many ways. So they use this methodology. So what was the benefit? So overall, for information collection, data collection, and also getting some outcomes also. So beyond what are the immediate uses, there may be some uses for research audit also. Okay, so those are the main things. So basically, you have these to assess and reassess, and then go forward. So only if you reassess, you will know whether your treatment is effective, or maybe sometimes something else may be the cause also. Every time what we do may not give the response what we anticipate. So in that level also, assessment is going to be helpful to see what is that I'm missing. Okay, so those are the wide benefits or reasons of doing assessment. Next, coming to how are we going to assess? So you have the numerical rating scale. Various types of scales are there. We can go on enlisting. But here what I would like to say is you have to use something what is feasible, best, and most useful for your local community. So because every place or every hospital will not have the same demographic type of patients. So you try to tailor make. These are the basic ones which are available, which we will tell. So you have to tailor make what suits your population and use it. So there's no hard and fast. You do what is best for your area. Okay, these are the various things available. You have the numerical one, visual analog one. You have something called as a dynamic pain assessment, because many times they'll say, oh, when I'm not doing anything, I don't have any pain. Once I start up or get up and walk, I am in agony. So you have to also assess dynamic pain assessment whenever they start to do or whenever they're doing any action. Because what is the ultimate aim? We want to improve functionality by the medications or whatever you're going to do. Okay, so that one. And then last, baseline pain assessment. Because to start off where I was and where I am now with the treatment. Okay, so those are the things. And for acute and chronic, you have an entirely different armamentarium of stuff which is used for assessment. So for the chronic one, because chronic one, as we have seen, it has got such a varied pathophysiology. So you have to have in mind in detail, in-depth assessment is needed. So each symptom, for example, site of pain, nature of pain, everything you can subclassify as mild, moderate, severe. And you can add on more components, burning, itching, tingling. So every aspect of pain. So nearly in very, very many questionnaires, there's something called as a Meggle pain questionnaire. Some 40, 42 limbs are there in that. So like that, each element can be explained in detail and you can get information in detail from the patient. And disease-specific scales are also there. For example, dementia patient, they have totally different type of assessment. Elderly, pediatric. So disease-specific, age-specific, very many type of assessment are there. And you also have other things. For example, whenever they have chronic pain, mood is affected. There are some scores, HAT scale scoring is there. How depression, sleep, everything, the pains influence on all those things. And separately, you have charts for neuropathic pain assessment also. So all these very many types are there. You use and make stuff what is needed for your organization. The next few slides, I'll just show you what are the different types commonly can be. This is a standard numerical one. See, in this itself, you have the number, the expressive one, mild, moderate, severe. You can connect it with the numbers. So all this, you explain to them and get the information. This is something very simple one. Even if someone is not able to read, write, nothing they know, these charts, body charts, they are set, they are very helpful and very useful. You can give it to them and ask them to fill the areas where the pain is. And then for our assessment also, if you have one, you can just use different colors. At my first, like baseline, you use red color. Then you give some treatment. You can use next blue for. So you can, in one chart itself, you can get a full picture of how they started, where they are, whether they get better or they get worse or some things like that. These charts are very useful because not only for us, for the patients also, simple, easy method of representation, and they may also feel comfort. This is a facial expression type of thing which can be used also. So these are the specific chronic pain assessment tools which I mentioned before. And then you also have ones which add on the quality of life assessment also can be done. Next is cancer pain. How is it different and what's that we need to know? Like in WHO, major impact on cancer-related pain management was done by WHO in 1986, mainly to get a satisfactory response. But still, see, 1986 is many, many years ago. Still, even latest figures, what they say is they are able to make analgesic drugs available, but maybe it's available in a country, but is it reaching the person who needs it? Still, that has not been achieved. The number achieved is only in single digit internationally, not only in India alone. Internationally, they say the drugs are available now, but that drug reaching non-availability of the drug to the point where it is needed. That is something where the whole world is struggling. Even in India, that's the situation. Maybe big cities have it, but even smaller towns and places are not having, but still we have patients everywhere. So that is where our role lies for us to find out how is it going to be made possible for them to get it. Next slide. So regarding cancer pain assessment, the Edmonton assessment tool is used. And main thing is that you have all the other elements also you have to have in mind. So if you see, as I mentioned, pain is on top, shortness of breathness is on the bottom. These are the two main things. But in between that, all what you're seeing are also important, like depression. So depression, anxiety could be all related to the pain which we saw. And then that in turn affects their activity. And basically because of their disease per se itself, they may have loss of appetite, fatigue. So they may not have a big level of well-being. So all these are interrelated. And so everything, that is the difference when you go into cancer pain assessment, you have to have all this in mind because they are all, some way or the other, they are interrelated. So you have to give importance and find all this so that only you will be able to manage the total pain what we saw. So next we will go on to management of pain. Okay. So basically today our session we are going to be seeing how to manage, and step 1 and 2 drugs is what we are going to do. So far, anyone wants any clarification, please do. Clarifications or anything else you want to ask in whatever we have dealt so far? So okay to move forward? Okay then. Regarding management, see for example, I have one methodology. A has one, B has one, C has one. What will happen? If each one wants to deal or do the management in one particular style, what will it lead to? Different patients will get different treatment. Okay. No. No start. Very good. Thank you very much. Chaos and confusion. That's what will happen because everyone will want. So to standardize, thank you very much. So to have a globally have one system, and the benefit also I'm going to say, if you have something as a standard protocol or guideline, makes our lives very easy. Okay. So that is why this WHO ladder was implemented. And it was based on the recommendations of a group of international experts. So they had everyone in the team. And so that no one says I was missed out. So it's a well-equipped team. And it was started initially for cancer pain, and it is there in multiple languages. Next slide. So main thing is to have uniformity. Okay. And the main important factors are it is simple, validated, and effective. See, no one can say what do all of us want to achieve? We want an effective tool, and it is simple and easy and validated. So all the ideal points which are needed are covered, and it is in a stepwise approach so that you know where to go. And see, so far what we saw, our assessment is going to help. The intensity of pain is what is going to help us to use the ladder and treat the patients. So this also legitimizes the use of opioids in pain management. Next slide. And the important points about the WHO ladder are these 5 points. Every point has a reason why it is there. Okay? By the mouth. So that means oral route. So which is the easiest and simplest of all? See, oral route can be. Go ahead. Did someone say something?
Oral route is simplest because it can be taken by the patients at home, no need of admission.
Exactly. Thank you very much. That's all. This is the simplest, can be done at home too. Okay. And FC, we have to look at option which we are looking. See, what I've been telling, it's available, but it's not there in rural area. Rural areas may not even have a hospital. Okay. But if it's an oral route, someone can deliver it and the patient can have by themselves. So that is the simplest and effective route. And the next one, by the cloth. Why that is important? Because if you say that the patient takes the medication as and when needed, then you will not get an effective pain relief.
Dr. Santosh, are you trying to come and
Say something? Okay, the thing is that for 5 o'clock, little bit of pharmacology and pharmacodynamics. So what is or how do you get your pain relief? Basically, you need to have the blood level of the drug should be available to get the maximum dose response. So for that, only if you take by the clock, that is the duration of action of the drug, is the interval what you should give for the patients to have the medications. So that is why by the clock is important. So they take in the correct time frame, the continuous blood level will be there for them to obtain the response. If it is not taken like that, and if it is taken as PRN or when required, so they will have pain, they will take it, and then they will not take it. So they will not get a effective and adequate pain relief. So unnecessarily, they'll be thinking that the medicine is not giving the benefit. If it is taken properly, it will give the benefit. So by the clock is essential to obtain the adequate required blood level of the drug. And by the ladder, depending on the severity or intensity of pain, you go and give what medications are needed. For the individual, are all of us alike?
Yes, ma'am.
No, like
No, no.
No, ma'am, no.
see, someone body weight 40 kilos, another one body weight 120 kilos, all the same?
No, no.
So that
Sure,
is why
no,
for the
yes.
individual. Okay, it has to be tailor-made. One size fits all doesn't work. Works for something maybe. Okay, and attention to detail. Why is that important?
To know whether the pain is somatic or neuropathic.
Okay.
or mixed pain,
That is one thing. Anything more?
and know the character of pain, know the intensity of pain,
Okay.
and know the socio-economic status of the patient and their families, so that we can know whether there is a component of socio-economic component of pain. I
Okay. Now,
can say like that.
attention to detail means what? So that is telling something important.
Previous drug history and analgesic intake history.
Suitability of the drug to the patient, whether the patient will respond to that particular drug, any side effects associated, patient may be allergic to that particular component of medicine.
Anything more?
The dose requirements may be different variable, so you have to set the dose in such patients, in different patients differently.
Exactly.
Depending
And
upon
then,
the intensity and depending upon the profile of the patient.
that's where, for example, someone has renal failure or kidney, like liver failure. So those type of things, you have to make sure that you titrate the dose. You can't give the same dose to everyone, no? So those also.
And patients,
go ahead.
Patients who are chronically on drugs, means they are in habit of taking pain analgesics, their requirement may be more than routine
That's
another
what. So
patient.
threshold, their individual threshold may be different. That is what. So you have to give importance to all these things. See, you can still, these are the important factors. Based giving importance to all this, we will still follow the ladder. That is what it is. So everything mentioned here is important when you go ahead and use the WHO ladder to treat the pain. Next slide.
And we also need to see if the cause that you've pinpointed is the only cause that the patient is having. The patient is complaining of pain. We need to see if the patient has some other cause, like maybe the has not passed, even the patient's retention bladder is distended, or if the patient has a fracture.
Exactly. That's what complete examination or assessment is important. See, pain is one of the symptoms. You have to examine the patient as a whole. So this is basic medicine. Okay. Any patient you see the patient as a whole. You just don't see that particular symptom alone. So even before treating, you should have done a complete examination. As you said, only then you will know the right cause. Anyone who does a complete examination will mostly or always do a correct diagnosis. The error or misdiagnosis will be very less there. So that is the important thing to be kept in mind. Okay. Why oral route is preferred? Because especially for morphine, and as I've said, no, that why the clock? Because analgesics should be taken at regular time intervals and not as needed. Okay, next slide. Advantages are what we have seen. It is simple and easy, validated, effective, universally accepted, and can be used for cancer and non-cancer pain, and well suited for home care, which we have seen before. Next one. This is the ladder which is the WHO ladder. It has step 1, step 2, and step 3. And the what we saw, the mild, moderate, and severe assessment of pain is what is going to help us to go through this ladder, go up the ladder. Okay. Generally, you go from step 1. If it is mild pain, you will start off with step 1 drugs and see the response. Gets better, continue. Or if it is moderate pain, you can use, see, for example, if you see step 1, you see non-opioid analgesics, that plus or minus adjuvant is, we will see through the session today, that is you can either add or not add. So that is what is meant in that. And then if the pain is moderate, from mild you go to moderate, you can add a weak opioid. Again, you can add a weak opioid and you can combine step 1 and step 2. Okay, you can have a weak opioid and a non-opioid also. And then still you can have the adjuvant plus or minus. Whereas step 3 is where you will have a strong opioid. So if someone comes with severe pain, you can miss step 1 and 2 and start with step 3 also. Okay, that is the normally we go from step 1 to step 2, but exception is when if someone comes in severe pain, they are in pain score of 10 by 10, that time you can't say that I will start slowly and see them. You want to ease their pain. So the exceptional rule which is allowed is if you see someone in step 3, like severe pain, you can start with step 3. So that is the main thing to be known about this WHO ladder. And we will see in detail about the drugs as we go. So this, as we have seen, depending on the mild, moderate, severe intensity of pain, you go ahead with what is needed, the type of management. And this we have seen, we'll go to the next presentation. Skip few slides. Regarding pain assessment, all of you are aware of all these things. Like as you should know the site of pain, nature of pain, extent, everything. All these are important because it's going to help you to move forward. Yes. Do you want to say something?
Yeah, I beg your pardon, ma'am. Actually, if patient is not able to take the medicine orally, like in oropharyngeal cancers or some laryngeal cancers, so is there any sublingual or mouth dispersible preparations of morphine and other opioids that we can use in our patients?
Liquid preparations are there, and then in that case you have other when you deal about opioids, you will be dealt with in detail or what are the other routes of administration.
Okay, ma'am. Thank you.
No worries. Next slide. Next one. Next one. So the main drugs in step 1 are the paracetamol and NSAIDs. Next slide. So paracetamol, even though it's a very common drug, it is found to be a very useful drug for cancer pain also. Okay. It is an effective and well-tolerated agent for mild to moderate pain, both as a single agent or in combination. Okay. And it has minimal toxicity in adults at generally recommended doses. But when you go to higher doses, that is when you can have some hepatotoxicity or renal damage. So generally, 10 to 15 milligrams per kilogram body weight is the single dose. Each time dose is 10 to 15 milligrams per kilogram body weight. And the total maximum daily dose is 4 grams for 24 hours. See, this is something to be kept in mind. And paracetamol as such itself, it is a very good antipyretic and analgesic, but not an anti-inflammatory. That is what we have to keep in mind. So we should be willing to use paracetamol, and not only willing, there is clear evidence to say that paracetamol is useful even in cancer pain. So it has that is what forms one of the step 1 drug. Next slide. So the dose, as I said, is 12 to 15 milligrams, and the potential for it is only when you go past the high dose, and it is safe for pediatric use also. IV paracetamol is very freely available, and 1 gram 6 hourly can be used. And rectal route also can be used when oral route is not possible. See, rectal 1 gram paracetamol can be used as a suppository for adults also. As he was asking, no, as Dr. Oves was asking, see, for example, you have some cancer patients having some multiple metastases, in bed bound or something like that. Acute pain, like they may be on some opioids also. In spite of that, they are not getting relief. You can give a paracetamol suppository, which helps because they may not be able to swallow. So in those conditions, even a rectal suppository will give relief. So as I was mentioning, the role of paracetamol in cancer pain is still the mainstay drug of the ladder because of the advantages what we have seen. And it can be added also as combinations to NSAIDs, tramadol, opioids. Every step of the ladder, you can add the paracetamol. Next. The main thing is that the NNT is quite low. What is NNT? It is the number of patients who receive the drug for one to have 50% pain relief over the period of 4 to 6 hours compared to a control. So whenever the lower the NNT, the more efficacious the drug is. So with paracetamol having an NNT of 5, it is an effective drug. So, and the toxicity, as I said, occurs only when you go up to 90 milligrams per kg per day. Okay. Next. And where all the toxicity can increase is if there is a pre-existing hepatic impairment, low body weight, and nutritional compromise. So these are things which we have to see. We know, as I was telling, it's a useful drug, but you should also know where and when it can cause trouble. So these are the things to be kept in the back of your mind. Next one. Next are NSAIDs. NSAIDs again are a group of drugs which produce their analgesic effect by working on the COX-1 or COX-2. Basically, in NSAIDs, you have either the selective or the non-selective. The non-selective one are the aspirin, ibuprofen, and which are commonly used, and naproxen also many of you may be using. And they inhibit both the COX-1 and COX-2 enzymes. And the main thing is their adverse side effects. So GI complications and renal toxicity is what all of us are worried, and that is what they cause. So next slide. So you need to know what each one does. The non-selective ones, like what are things that commonly all of you use? NSAIDs.
Ibuprofen.
Can't hear you. Brufen. Brufen and Voviron. Okay.
Cyclophonac.
Cyclophonac. Okay, so commonly ibuprofen is used, and then so basically the dosage is what you can do, 400 milligrams, 6 or 8 hourly, and maximum dose is also given, and the NNT is again 2, low, again it's effective. Naproxen is also used widely for arthritic type of pain. And you need to remember that naproxen is eliminated by the kidney, and the maximum dose is, it's normally given as 12 hourly. Next slide. So main thing you have to understand is they have their impact on nearly all systems. Cardiovascular risk also is there. Renal risk is very well known. GI also bleeding incidences everyone is aware of, and there can be some hypersensitivity also. Next slide. So next, selective COX. They are associated with reduced GI, but still they can have renal toxicity. Okay. So you need to be aware of this. Okay. And there is some amount of cardiovascular risk also documented very well. So the main thing to have in mind is what I'll show in the next slide and the other one. So basically, not that they are not useful at all. If they are used wisely, they have the benefit. But if they are used without knowing the important and their worst side effects, it can lead to renal failure in very young people. So we have to tell them what are the plus and minus of it. Because in many parts of India, all of you will be knowing that you have so many young patients being on dialysis for so many times a week. 30-year-olds, 35-year-olds are on dialysis. So if you find out the history, they would have been on these NSAIDs for years. without their knowledge, because one prescription they would have got and they would have continued it for umpteen years, ending up where they are. So it is our responsibility to use it wisely, not that it should not be used. It has to be used wisely. Next slide. And with topical NSAIDs, you have both the patches, gel, all available. They provide effective analgesia in musculoskeletal conditions, and generally the systemic absorption is said to be less when it is used topical. So that is, again, you can recommend them to use more topically than orally. Next slide. So this is one important take-home slide, I would say. Okay, the lowest effective dose should be used for the shortest duration required to control symptoms, and the need for ongoing treatment should be reviewed regularly. Okay, so this is very, very important. So hope this is clear to everyone. Anyone would disagree with me?
Oh, ma'am.
So the main thing is that, see, as anesthetist, I've even used it intravenously, okay, a lot of times. So I'm not telling you that you should not use it, okay? Use it short term. When someone is in acute pain, or that is even a chronic, see, a chronic pain person can also have an acute exacerbation, okay? Those times use it wisely for short period, for 2 days, 3 days. For example, in malignancy, bone pain will not respond to morphine sometimes. You may need an NSAID, okay? So use it as and when required. Use it for short time. See, I'm going to read this once again, because this is something, if every one of you take this and use it in your practice, that will be one of the very important things. Lowest effective dose should be used for shortest duration to control symptoms, and the need for ongoing treatment should be reviewed regularly. Don't give one prescription and they can keep on taking. Please tell them that they can use it, and when it is bad, and then not to continue it regularly. There are other ways of managing. Okay. The weak opioids are tramadol and tapentadol. So tramadol is one of the weak opioid, and it has its action on the mu receptors, and also it also has an effect on noradrenaline and selective neuron serotonin reuptake. So it inhibits. Those are the two main modes of action, and it is normally started at 50 milligram dose. You can start from twice daily, 3 times daily to 4 times daily, and the maximum dose is 400 milligrams per day. Next one. Next is tapentadol. This again depends on availability. It is available in India, and the action is similar to tramadol, same mode of action, and it is available in strength also 50, 100, 150 milligrams, and 6 to 8 hourly or doses are given. And the main thing is that with tapentadol, the side effects are said to be lesser compared to tramadol. Next. The adverse effects for both are nearly the same: nausea, vomiting, dizziness, and it can cause hallucination and confusions. And one more thing to be kept in mind is seizures may occur with use when you are using drugs, because this has a tendency to lower the seizure threshold. So when patients are already on some other SSRI or NSNRI drugs, so you have to have in mind. But generally, in this long experience of using the drug, because what we use, when we see the adjuvants, I will tell you, the dosage, if it is in low dose, the risk is less. Always the complications are dose related. So that is what you have to have in mind. As when we see the adjuvants, I will explain. Next slide. What are adjuvants? What is the meaning for adjuvant?
Supplementing the action.
Yes. So this is, they indirectly help pain. Okay, next slide. So basically, they help or facilitate pain management. So something which is going to help in the pain relief. Next slide. So in this group, we have got a variety of drugs. We will just see the important ones. The main groups are antidepressants and anticonvulsants. The first group, what is, because antidepressants still are the first line of choice. As per any guideline, if you see, the adjuvants, if you see, this is one of the first recommended group of drugs which is used for pain relief. And the mechanism of action is basically how exactly it works is not clear, but the analgesia effect is attained at a very low dose. Normally, an antidepressant dose will be 8 to 10 times the dose of what we use for pain relief. So, for example, you will use 12.5 milligrams or 25 milligrams to start off. Whereas normally, as an antidepressant, you will use higher dose. So, because we need to tell this to patients for them to understand. As soon as they say the name, oh, antidepressant, I am not depressed, I don't need this. That's what they will say. Okay. So what dose we are using here is a very low dose. It is, as he said, to supplement the action to get better pain relief. Okay, next slide. And the main drugs are tricyclic antidepressants, SSRI and SNRI. This is what I was telling, when you're using these with tramadol, these also have seizure tendency. So when you're combining both, because you're using very low dose of this, them causing higher incidence of seizure activity generally doesn't happen. But you need to know what can happen. That is why it is generally mentioned. Next slide. Efficacy-wise, the tricyclics are said to be the most efficacious compared to the rest. And side effects also, tricyclics are said to have the more side effects compared to the rest. What are the main contraindications? If someone has a conduction defect or cardiac arrhythmias, it's not used. And if there is narrow angle glaucoma or prostatic hypertrophy, caution to be kept in mind. Next group is anticonvulsants. Anticonvulsants, why they are used? Basically, we saw in the pathophysiology, there is hyperexcitability of the nervous system. Okay, we want to dampen the hyperexcitability. So that is why anticonvulsants, because they have the capacity or capability to dampen the excitability, neuronal excitability. Normally, anticonvulsants are used. The ones which are commonly used are gabapentin, pregabalin, sodium valproate, and all of them, the main underlying mechanism of action is reducing the neuronal excitability. Next slide. So this is a difference between gabapentin and pregabalin. For gabapentin, oral bioavailability is unpredictable, whereas for pregabalin, it is predictable. And slow titration is required when you use gabapentin, whereas when you use pregabalin, the titration could be achieved in less time. The main difference is the cost. Gabapentin is less expensive and pregabalin is more expensive. Next group is corticosteroids. Corticosteroids play a big role. They are useful in very many types of pain management because in varied groups it can be of help. It is found to be useful in neuropathic pain, bone pain, and like pain due to raised ICP, and also for arthralgia, and also for obstruction, if there is any bowel obstruction type of symptoms, and pain from spinal metastasis. And the commonly used one is dexamethasone. It has a long duration of action. And the main benefit is it has less mineralocorticoid effect. And only one important thing I would say is generally it is given either as a single dose, or even if you want to give it as 2 doses, the final dose should be given latest by 2 o'clock or something like that, so that the normal circadian rhythm is maintained. They don't have insomnia or other side effects affecting their general day-to-day routine. Next slide. Other drugs which are other adjuvants are ketamine and local anesthetics, which are commonly used as an inpatient management option. Next slide. So the main thing is that multiple drugs are there. Okay, all these are used to aid or help in the pain management. So that's what is the list given there. And for specific type of pain, what are the specific drugs which can be useful is enlisted there. I think that's. Anybody wants to ask anything?
Thank you so much, ma'am. We can take up a few questions. We'll wait for some time if someone responds. It will also be interesting to hear what your practice is in terms of the adjuvants. Do you use adjuvants routinely in your practice? What is the drug of choice in your setting, and what is your experience in using adjuvants? It will be interesting to hear.
A wide variety of, like, people are from different places. It will be better to know what regional variations are there.
Well, in cancer pain, we are using gabapentinoids, like gabapentin and pregabalin. And for trigeminal neuralgia, carbamazepine and oxcarbazepine. And others mostly is carbamazepine. And we are using lamotrigine also, levetiracetam sometimes. And depends on the which type of neuropathic pain patient.
Levetiracetam, can you take that you use for as an adjuvant?
Sometimes patient has seizure history, then on these patients.
No, that may be their primary drug for the seizure, no?
Yes, ma'am.
So that's the main thing to keep in mind. See, if they may be on some drug, if you see, that is where you will get a clear idea of the dose. They may be on that dose 3 times a day. The dose may be higher. See, these are to be kept in mind, that which is if they are having for primary treatment of epilepsy, and what is the adjuvant used there. Gabapentin, you mentioned you use both gabapentin and pregabalin.
Yes, ma'am.
So like anything you have seen personally of the two, anything is better? Elderly, what do you use generally?
As pregabalin is associated with weight gain and edema, peripheral edema, so we avoid giving pregabalin to the elderly patients.
So there you use gabapentin.
Yes, ma'am.
No, both. Okay, both can cause weight gain. It's not that.
Weight gain is more with the pregabalin.
Sedation is comparatively less with the gabapentin as compared to pregabalin.
It will be relatively less with anything else. These two only are said to cause more incidence of weight gain. So you don't use much of tricyclics?
Yes, ma'am. We are using carbamazepine, oxcarbazepine.
Triptyline, not triptyline.
Triptyline, not triptyline also. Yeah.
Now, what setup, where do you work, Dr. Manoj? Is it a private one or a government setup?
No, government setup.
Government setup. So availability of all these are there. So you have availability of both tricyclics and gabapentinoids. Very good.
Yes.
See, for example, you were telling trigeminal. Herpetic neuralgia, PHN, what do you use? When you have elderly people, you would get a lot of post-herpetic neuralgia also. Does anyone see those patients, or have you had the opportunity to see?
Yes, ma'am. We see post-herpetic neuralgia patients.
So for them,
And
what do you use?
amitriptyline is the drug of choice, and with the gabapentinoids.
See, for generally, for post-herpetic neuralgia, gabapentin works very well. And even with elderly, you can start with 100 milligrams dose. Because see, most of them are at least 70 plus, okay? 70 plus, 75, 80 plus. You start with 100 milligrams, titrate that to 100 milligram TDS. Mostly, even very well-built people with 300 or 600, they could get very good response, and in 6 months or so, they will be pain-free.
Yes,
There is like lot of patients do get benefit from that.
Ma'am,
100 milligrams can work. So not to think that 100 milligrams won't work. And in elderly, especially 100 milligrams works. Dr. Geeta Anjali, go ahead. You wanted to say something.
I just wanted to add that in our setup, ours is a government setup. And for post-herpetic neuralgia, we often use pregabalin, 75 milligram BD as a monotherapy. Some patients, we have also used duloxetine, 30 milligram BD, again as a monotherapy. And as a rescue, if patients doesn't get relief with any of these monotherapies, then we also try giving them a combination of both. Pregabalin and together.
And duloxetine.
Yes.
So do you combine
both as a combination, as a rescue therapy? If they do not respond to the monotherapy, we try giving both of them.
So what would be your opinion, like, for example, if you have a comparative analysis between duloxetine, like you have duloxetine patients on one arm and pregabalin, was there any, I would like to know.
When we did a literature search, we observed that most of the research articles and what is being practiced most commonly is that people use either pregabalin or duloxetine as a monotherapy. And this combination is only used as a rescue therapy. In our setup, we also did a randomized control trial where we compared pregabalin monotherapy with the combination. And we observed that with the combination therapy, ma'am, the pain relief and the quality of life, all these things were better when these two drugs are given in combination from the time of diagnosis itself, not as a rescue, but from the time of diagnosis itself. If it is started, the patient outcome is better.
Always, that is very, very important, especially with post-herpetic neuralgia. You should start from the beginning, okay? As soon as their shingles disappear, and when they are in that stage, if you start, you can get very good relief, because someone who doesn't have pain relief in the beginning can end up having pain for even 2 years, okay? But if you start someone with pain relief also, as soon as their shingles disappear and things like that, within 6 months, they may get full pain relief and they may not have pain episodes later at all. So very good, thank you. So those things are useful. Duloxetine is like, depends on individual response, and if they have done a study and found to be useful, good.
Ma'am, we use duloxetine as an add-on, not as a first line of the drug.
Exactly. That is what, that's why I was, see, I also don't, I'm not a person who would use dulox, because per recommendation and guidelines, duloxetine is not first line. Okay. It has got QT prong, it has got its own things. So, and again, I'm not telling that you should not use. Okay. It should be used appropriately. And it's not a first line, because any guidelines or anything we take up and read, that will not be a first line of choice, first drug of choice. Good. Anything else? Diabetic, correct. Diabetic neuropathy is the first line of Duloxetine, that is the recommendation for.
Tapentol, what is the dose and is it?
Same like tramadol.
Okay.
Like maximum is 400 milligrams. 50, 100, 150 are there. 8 hourly you can give. Is it available in your place?
No, we don't know. We don't have it. That's why we're asking.
No, but it is available in some places. It is mechanism of action. Everything is like tramadol. 100, 150 milligrams 8 hourly you can use. Same, max is 400 milligrams per day. It is available even as 50 milligram tablet. Only thing, see, for example, tramadol 6 hourly you use this, you will use it 8 hourly.
Okay. Thank you.
Is there any other questions? Yeah, I was just commenting on tapentadol before you.
Exactly. That's
that
what. So
I
same.
find it there are like it is very close to the efficacy is very close to step 3, strong opioid, slightly better than tramadol with lesser side effects.
Yes, because I remember Dr. Vidya mentioning they use a lot. They in fact use only tapentadol instead of tramadol. That's what I remember her telling, because mainly with less side effects and better benefit. So
Yes.
tapentadol, many studies are also there. I've also used it for short time when I was in England. It is useful. Mainly less side effects and better, it's better pain relief. So that is what would be useful. Here also I heard it is available in many places.
Yes,
So
it is available. I have used it for quite some time. It is the side effect profile is the nausea, vomiting is slightly lesser compared to tramadol. And the pain relief action, the opioid action is slightly stronger than the tramadol, which is comparable to morphine is what they say, but
correct. So that's the benefit. No, that's what we want for the patients. So
I guess there are no more questions. We can wind up today's session. A gentle reminder to everyone to fill up the pre-test, because that is very, very important for us to understand our own delivery of training program. So please fill in the pre-test. It won't take long time. It is very short. Won't take a lot of time from your side. So please do that today itself if you have not done it so far.
they have to do it earliest, Sri Devi. Only then the impact of our training itself cannot have an influence on it. So please kindly all
We were
of
supposed to do it sometime 2 days back, but we have not received all the participants.
So that's all. Maybe today everyone will try to send it in.
So there is a question. Sorry, there is a question. Why there is no sublingual opioid available? Any response to that? I've heard fentanyl.
Sublingual fentanyl available, ma'am.
No, fentanyl is available, no? That lollipop is there.
Yes.
Lollipop.
Yes.
There are also patches.
Liquid only is there.
Sorry, Dr. Abraham, you're talking about buprenorphine, right?
Patches. In addition to instead of sublingual, you can consider the patch if you.
Patches are available. Even fentanyl patches and lollipops are available. The other opioid, methadone, that will be covering tomorrow, but it is also again available in syrup forms. Some of the centers have syrup form of morphine. But it is not available everywhere. But yeah. Yes, Dr. Hamad, yes, they are all costly. And in our experience, we can manage almost many types of pain with whatever is available in the limited setting and with the cheapest medications possible. I think you will have more idea after
No,
tomorrow's session.
fentanyl lozenges also are available. Not that no
Yes.
sublingual is available. I have seen fentanyl lozenges are there, but again, very expensive they are. Compared, see, you have something which is cheap and best, and you have something which is expensive. It is all what need based. If some private setup wants only expensive ones, that's also there. But for the needy and poor who need pain relief, easily available, morphine at lowest cost is also available. So the world has got everything. You can choose what you want.
Yes, Dr. Ahmed, please ask your question.
I want to share my experience at our place, Srinagar. We usually use morphine with honey. We use 10 mg tablet, we crush it and mix it with honey and give to our patient, and they get instant relief, I think, with this preparation.
Yeah, we also use that when patient is unable to swallow, but it is not the sublingual absorption. It is a gradual absorption.
No, it's not sublingual, but it is. Yeah,
it is very effective. It is very effective. Patients who cannot swallow, we mix it, powder it with, and mix it with honey. Thank you for sharing, because the honey is very thick also.
Yeah,
So
yeah.
it
I
won't
want to
cause
share
much
it so
of-
that someone get benefits of it again.
Wonderful. Thank you.
Exactly.
Thank you, Doctor.
Really nice.
Thank you, ma'am.
See,
Thank you, ma'am.
Common sense always helps us.
Yes, ma'am.
Somebody has raised their hand.
I think it was Dr. Ahmed who was talking.
Okay.
Yeah, I'm from Skims Sora, Srinagar.
Okay. Thank you.
Thank you, ma'am.
So thank you so much, everyone. So we'll meet you tomorrow again with another topic, opioids. Hope opioids will have a lot of interactions and questions, because that's one area everyone will be interested in. Shripriya, over to you.
Thank you, Dr. Radha. Personally, seeing her, I know you are a very busy person. The moment she lands in Kerala, she starts traveling. And again, your travels are scheduled. Still, you found out time for this wonderful batch of people, and you shared your knowledge, your experience with us. Thank you so much for that. Thank you, everyone, for joining. And we do hope that some of you at least might have had a enriching experience today. And with just again another humble reminder that please do fill up the pre-survey, and a promise that we'll be meeting again tomorrow with more knowledge to be shared among ourselves. This is Sripriya, along with Dr. Radha Venkatesan and Dr. Sridevi Warrior, signing off from the Tips Eco. See you tomorrow, same time. Till then, everyone, take care. Bye-bye.
Thank you.